We're going to kick off with 2 presentations and then go back to the panel conversation. So have your questions ready. And first up from Johns Hopkins University is Dr. Erin Michos, who will be talking to us on diagnosis and management of acute MI in women, how to address sex and gender-based disparities.
Thank you very much for having me in this special symposium. So as you heard, cardiovascular mortality is on the rise in young women. The figure on the left is one of my studies looking at mortality in women under the age of 65. And in younger women, cancer is the leading cause of death. And we showed over these past 30 years that cancer mortality is continuing to decline in young women. However, heart disease mortality, shown in the red line, is no longer declining. In fact, since 2010, it's on the rise at 0.5% per year. So if these trends are not overturned, heart disease is set to overtake cancer as the leading cause of death in young women, too. In fact, the fastest growing heart disease death rate is actually in middle-aged women, age 45 to 64, which has increased 7% since 2017. So I'm talking about sex differences in MI diagnoses. So, when I Google heart attack, I got these images on the left, and, I think it would be hard to kind of miss a heart attack if you see this, white male with gray hair walking into your emergency room clutching his chest. But actually, the figure on the right is also a heart attack survivor. She shared her story with a local newspaper. She had a SCAD, a spontaneous coronary artery dissection, as the cause of her heart attack. And I take care of a lot of SCAD patients, and they often tell me the same story, that often they have a delayed recognition. They're often even sent. I had one patient that showed up to the ER 3 times before she finally got an EKG, because they don't look like what a heart attack should look like. They're generally younger premenopausal women with no risk factors. So it's important to take all women's symptoms very seriously. Now, I want to dispel this misconception that women don't have chest pain with their ischemic symptoms. The data does not bear this out. Actually, women, when they present with myocardial infarction, have chest discomfort the same amount as men. It's just that women often have many other associated symptoms with their myocardial infarction, and often these associated symptoms can be distracting and leading people down to another path. This is one example on the figure on the left, where it's myocardial infarction patients describing their chest pain, and the color in the red is the women, and the color in the blue is the men. And you can see that actually the presentation is very, very similar. Over 90% of both men and women had chest pain as their presenting symptom. And this is another study from the Virgo study of young acute MI patients. And again, 90% of young men and women presenting with an MI had chest pain. But women were more likely to have 3 additional non-chest pain symptoms with their MI. And furthermore, among patients who had sought care for their symptoms prior to their index myocardial infarction event, women were more likely to be told that their symptoms were not heart-related. So how can we improve diagnosis? So you've heard alluding to using the high-sensitivity troponin assays with sex-specific cut points. This is one study that looked at diagnosis of MI in men and women. We're using contemporary troponin assays and high-sensitivity assays with a uniform cut point and then sex-specific cut points, of which the threshold for this for high-sensitivity troponin I was above 16 nanograms per liter for women. And if you use sex-specific cut points, this actually increased the diagnosis of MI in women by double, from 11% to 22%. But this really had no minimal effect in the change in diagnosis on men. Now, does reclassification using sex-specific high-sensitivity troponin assays matter? Well, yes, it actually does matter. In that same study, women on the left that were reclassified using the sex-specific troponin, high-sensitivity troponin assays, these are in the red bars, actually had the worst outcomes over follow-up. The green bars is women that would be diagnosed with MI by both conventional and the sex-specific troponin thresholds. So reclassification mattered. Now, these delays in care are both on the patient side and the health system side. We need to do awareness for women, too. In AHA surveys, only 53% of women said they would call 911 if they thought they were having a heart attack. The majority of them would have called 911 if they thought somebody else was having a heart attack, but not for themselves. And lack of expected symptoms, can lead to delay in care. And this is an older study, but still was quite striking. It was a study that looked at patients who had presented to the emergency room and were inappropriately discharged, failure to recognize that we're having a myocardial infarction. And younger women under the age of 55 were 7-fold more likely than other sex and age groups to be discharged inappropriately. Now again, the delay is on both sides, the patient side and the healthcare system side. And in STEMI, we know that time is of the essence. Minutes matter in STEMI. And in this large metropolitan region, there was delay both with, for women, symptom to first medical contact, symptom to door, was 27 minutes longer in women compared to men. So women were staying home longer with their symptoms before they sought care. But then once they were within the medical system, the time from medical contact to reperfusion therapy, the door to balloon time was also 13 minutes longer. So that's the delays on us in the healthcare system. And that was US data, but here's data from Australia, which showed a similar thing from their STEMI registry, that in STEMI, the symptom to door time in the gray bars were 29 minutes longer in men, so women waited home longer. And then door to balloon time, once they were in the system, was 8 minutes longer in women. And women also had, in that same registry, in STEMI, a 67% adjusted higher 30-day mortality compared to men, so the outcomes were worse. So I love these chest pain guidelines led by Dr. Galati, and of course this is an evaluation of all chest pain. Not all of it turns out to be acute coronary syndrome, but relative to acute coronary syndrome, I just wanted to highlight the C, that chest pain is more than pain in the chest. The H, to use high sensitivity troponins, is preferred and use sex-specific assays. The E, to seek early care for symptoms. The A, the associated symptoms. Women have more symptoms in the setting of their MI. And the N, to avoid the word atypical. Atypical leads to delayed diagnosis and under-treatment. So it's either cardiac chest pain or non-cardiac chest pain, and we do women a disservice when we call their symptoms atypical. Now, in the setting of acute coronary syndrome, we see across all these trials, as you heard, that women are more likely to have non-obstructive coronary disease, women in the black bars, compared to men. And there's many mechanisms, even in the absence of coronary stenosis, of how one can have myocardial ischemia, and you've been hearing about some of these today, including vasospasm. And I love this phrase I first heard from Dr. Noel Berry Mertz about mechanisms for acute coronary syndrome. So men are more likely to explode. They're more likely to have plaque rupture. But women are more likely to have plaque erosion as the cause of their myocardial infarction. And in 2019, we did have this nice algorithm for the workup of MINOCA, myocardial infarction with non-obstructive disease. So first, the MI in MINOCA is MI. We have to make sure that there's really a myocardial infarction. So you have to have the rise and fall in the troponin, a positive biomarker above the 99th percentile, and plus or minus some other ischemic signs and symptoms, and then non-obstructive disease on angiography. And then make sure that you go through your working diagnoses, make sure you're not missing obstructive disease or some other cause of myocardial injury like myocarditis. And then if you think you have a patient with MINOCA, as we'll hear from Dr. Reynolds, you have increased utility for diagnosis when you can do a combination of coronary imaging through IVUS or OCT and cardiac MRI. In fact, hopefully we'll hear from Dr. Reynolds about her nice HARP study. But in this cohort of women with MINOCA, the combination of using OCT and cardiac MRI was able to come up with a diagnosis in 85% of the time, of which 75% of the cases were ischemic and 25% were non-ischemic. So sex difference in treatment for MI. So there's significant disparities. We've heard about this. After MI, women are less likely to be initiated on preventive pharmacotherapy, they're less likely to be adherent, and they're less likely to be in optimal medical therapy 1 year after discharge. And if you look at the figure on the right, the greatest disparity about not being on guideline-appropriate therapy was for women ages 20 to 54. And this is another example from a different cohort in Finland about young adults under the age of 55 with MI. And again, even after you adjusted for risk factors, women were less likely to be revascularized for their MI, and they had less utilization of evidence-based secondary prevention medication. men had a greater odds of using PTY12, being on RAS blockers, on statins and high-intensity statins. Although interestingly, despite the underutilization of medications, male sex did have worse outcomes, and it may be somewhat due to different mechanisms underlying these myocardial infarctions. And this is just another busy slide. Again, for each column, it just has medications at discharge at 6 months and 1 year across various cardiovascular medications. And the women in the orange bars were underutilized compared to men. You know, at 1 year, women were 3% less likely to be on antiplatelet therapy, 4% less likely to be on statins, and 4% less likely to be on ACE or A or Bs. And now things were a little bit better with STEMI, where women were a little bit better treated with STEMI. But when you looked at non-STEMIs, men were 20 to 30% more likely than women to be treated with this guideline-directed therapy. So in terms of outcomes, we've heard about this too, that women do worse after STEMI, particularly younger women. They have higher mortality than men. It's a little bit more similar for non-STEMI. This is another population-based cohort from the United States, from Minnesota, and unadjusted analyses after MI. You know, women had worse outcomes with recurrent MI and heart failure and death and CV death, but women, of course, were older and had more comorbidities at their time of MI. But even after you adjusted for these risk factors, women were more likely to have a recurrent myocardial infarction. Furthermore, this analysis of MI with cardiogenic shock, women do worse, in this most severe form of myocardial infarction with cardiogenic shock. This was from the national inpatient sample of adults under the age of 55, that younger women with MI with cardiogenic shock were less likely to get angiography, they were less likely to get PCI, they were less likely to get mechanical support, mechanical circulatory support. And across all these different groups, the odds of dying in the hospital with their MI with cardiogenic shock was higher in women than in men, particularly among the women who didn't get mechanical support or PCI. And an adjusted in-hospital mortality was 11% higher. Now, if women make it through the discharge, they're actually more likely to be rehospitalized 1 year after their myocardial infarction. So women are in the gray lines and men are in the black, and the solid lines are younger under the age of 55, and the dotted lines are above the age of 55. But you can see, regardless of the age group, women are more likely to be rehospitalized. And some of this has to do with the underutilization of guideline-directed medical therapy that we've talked about. But some of it is also about unaddressed psychological factors like depression that lead to women having less suboptimal outcomes. And then one topic that I'm very passionate about is we need to enroll women in trials. Trials provide our evidence base that shape our guidelines, and there's consistently an under-enrollment of women in randomized clinical trials. Now, this isn't specific just to MI, but in this editorial I did with Safi Khan, we reviewed the literature across all kinds of cardiovascular trials for different entities. What we showed here in the purple is the proportion of disease experienced by women in the population, and the pink bars are the proportion of women in trials. And so for each of these cardiovascular entities, women are under-enrolled in trials relative to their disease burden in the population. And so this limits our knowledge about efficacy and safety of these therapies. And so I had the pleasure of working with Dr. Galati on this clinical practice statement for the American Society of Preventive Cardiology about how we can increase enrollment of women in clinical trials, such as including women in the design, patient-centered design, diversifying the study team and investigators, having more inclusive criteria to make sure we're not overly excluding women with barriers for enrollment, education, emphasizing the benefits of being in a trial, having more flexible follow-up, avoiding hidden costs, and engaging women patients in the dissemination, and making sure we're collecting sex-specific endpoints. So in conclusion, women with MI are more likely to have more associated symptoms, have MNOCA, have a decreased coronary vascularization and longer ischemic times to their revascularization, less utilization of guideline-directed medical therapy, less referral to cardiac rehab, and more mortality after STEMI. And I really like this figure from Dr. Mehran that puts it all together on this slide, that the incidence of MI is increasing in women. Women have both high prevalence of traditional and non-traditional and sex-specific risk factors. to avoid the word atypical chest pain, which leads to delayed diagnoses, that make sure women have access to seek care in a timely fashion, and then to be considering about these other etiologies for non-obstructive disease that are caused underlying the myocardial infarction. And this is a review that I got to participate in recently for European cardiology reviews. Just how can we improve outcomes? Well, we want to use systems and checklists to make sure that we have proper identification of the cardiovascular disease in women in the first place, make sure we're starting and titrating guideline-directed medical therapy, that we're continuing to engage in lifestyle modification, including cardiac rehab, and increasing representation of women in cardiovascular clinical trials. And with that, I thank you for the opportunity to speak.